I want to thank SAGES for this opportunity to present this research. My name is Amir Aryaie. I'm the current MIS Bariatric Fellow at Case Western. I have no disclosures. Dr. Mark's disclosures are stated here in the slide. Self-expandable metal stents are used traditionally. They were originally FDA approved for malignant stenosis. However, in the past decade, we have been pushing the envelope using it for benign strictures, leaks, and perforations. There are currently 3 different types of stent coverings: uncovered, partially covered, and fully covered stents. Originally, most of the malignant stenosis used uncovered stents. However, due to the tissue ingrowth and restenosis, majority of physicians are now using partially covered versus fully covered stents. And in cases of leak or perforation, majority of physicians are using fully covered stents. However, stent migration frequently complicates management, and reviewing the literature, the stent migration ranges anywhere from 3.7 to 50%, depending on the type of stents used. And this may require further procedure or surgical removal of a stent at sometimes. The purpose of this study was to determine predictive factors for stent migration. We reviewed all of our SEMs placed in the foregut from 2009 to 2014. No specific exclusion criteria was included. And this data was reviewed retrospectively from a prospectively maintained database in REDCap. Demographic data, type of surgery, rate of stent migration, and type of stents, whether it was fully covered, partially covered, or uncovered, were collected. And using appropriate data analysis, rate of stent migrations were compared. We found a total of 214 procedures that had SEMs placed in the foregut. Mean age of patients were 65 with mean BMI of 27. There was no difference between male and female ratio, and all comorbidities were evaluated. Indications for stent placement in the foregut include anastomotic leaks, strictures, staple line leak, malignant stenosis, benign stenosis, malignant perforation, benign perforation GI bleed in one case, and fistulas. Here's a list of surgical complications that led to SEMS placement in the foregut. Looking at our total number of 214 procedures, 43 of those had stent migration. And out of those 43, 33 required stent removal, and 27 of those stents had to be replaced to further treat the patient. Total of 2 patients had major complications from bleeding from an aortoesophageal fistula, one of which resulted in death. And 1 patient had a significant stent migration that required bowel resection. And mucosal friability was noted in 10 of the procedures after stent removal. Looking at all comorbidities and using binary logistic regression, it was interesting to find that history of diabetes and malignancy were related to significant stent migration. However, when we look at the malignant stenosis by itself, we do not see a significant rate of migration in this series. And further evaluating whether the stent was fully covered, partially covered, and uncovered stents, we noticed that 30% of the patients that had fully covered stents had stent migration. Again, this was statistically significant. Comparing all the procedures that required stent placement, post-esophagectomy and gastric bypass anatomy, again, they were more related to stent migration compared to the other procedures performed. We also evaluated patients that had stent fixation versus the ones that didn't have stent fixation. However, there was a big difference between the 2 groups, 11 patients in the group that had stent fixation and 203 that didn't have stent fixation. But again, due to the large difference between the 2 groups, we did not find any statistical significant difference between the 2. And even evaluating the fixation group that had endoscopic suturing to fixate the stent, half of those had still migrated. So in conclusion, in our series, comorbidities including diabetes and history of malignancy are related to stent migration. Treating complications of esophagectomy and gastric bypass are again related to stent migration, and use of fully covered stent is related to much higher rate of stent migration. In our studies, we didn't have a sufficient power to determine if fixation was associated with less stent migration. There needs to be clear indications as we move forward. We're pushing our envelope to place these stents for leaks and other indications that was not originally FDA approved. We need to have careful consideration and clear follow-up for these patients. And there needs to be alterations in future to prevent stent migrations, as currently we're relying on radial force of the stents to prevent migration. However, this may be a good way of preventing migration in, for example, aorta. It doesn't necessarily work in GI tract, as the GI tract is more compliant and stretches easier. Thank you.